Thank you. Okay, all right, okay. Good afternoon, everybody, and welcome to the West Berkshire Health Scrutiny Committee. I'm Councillor Martha Vickers, and I'm chair of the committee. Other members of the committee present this afternoon are Councillor Nick Carter. Oh, you haven't got your name in front of you, Nick. Never mind. Okay, this is Nick Carter. Nigel Foote and Councillor Owen Jeffrey. Councillor Alan McCrow is also present over there on the screen as Executive Portfolio Holder for Adult Social Care. Thank you for joining us, Alan. And Adult Social Care and Health Integration. Council officers and external partners joining us to advise and support the meeting are Paul Coe, Interim Executive Director for People, Sarah Webster. She's over there on the screen, is she? Sarah Webster, Executive Place Director, Berkshire West Place from Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board. Fiona Warby, Lead Officer for Health Watch, West Berkshire. Catherine Greaves, is she? Oh, she's over there. Oh, hello. Catherine Greaves, Senior Programme Officer, Public Health. Sarah Johnson, Dementia Service Lead, Berkshire Healthcare Foundation Trust. Heather Howells, she's on her way, GP Clinical Lead, Mental Health, Dementia and Learning Disabilities, Berkshire West, Bob, ICB. Leila Johansson, are they coming? She's online. Leila's over, oh, she's over there, hello. Lead for All Age Mental Health, LD Autism and Special Education Needs, Bob, ICB. Teresa Wiles, Divisional Director, Mental Health, Berkshire Healthcare NHS Trust. And I think Dr. Heike Veltman will be joining us later. GP Joint Chair Bob, Integrated Cardiac Delivery Network Manager, and lead for Cardiovascular Disease Programme Board. And Sarah Bow also joining us later, Bob, Integrated Cardiac Delivery Network Manager, ICDN, and Oversight of Long-Term Conditions across Berkshire West. Vicky Phoenix is the clerk for the meeting, and the meeting is also being live streamed on YouTube, and Gordon Oliver over here is the Zoom host. Before we start proceedings, I'd like to explain for the benefit of members of the public who may be watching that this afternoon's meeting is being held both over Zoom and with councillors present in the council chamber. The meeting is being live streamed on YouTube, so members of the public are able to follow proceedings. And please can I ask everybody in the meeting to make sure they switch on their microphones when invited to speak and to switch them off when they finish speaking. If we hear the evacuation alarm this afternoon, we must leave the building immediately via the emergency exit. That one over there. Which is the emergency exit? This one over here? That one over there. The assembly point is the Dolphin Car Park. So just follow the officers if that happens. If the lockdown alarm sounds, we'll remain seated and await instructions in the meeting until such time as it is safe to proceed. Do members have any questions about the way in which this meeting will be conducted? No? Okay, right. Vicky, do we have any apologies?
Yes, Chairman, we've received apologies from councillors Jane Langford and Stuart Gawley. Councillor Nigel Foote is substituting.
Thank you very much. Thank you, Nigel. And we now need to confirm the minutes of meetings held on the 14th of March and the 25th of May. Can I have a proposer for the 14th of March?
I propose.
Councillor Jeffrey, and a seconder. Okay, obviously we weren't at these meetings. Well, we were at the second one, but we not at the first, but we can still propose and second as it should. Thank you. And that was Nick Carter seconding. So I sign this one. Oh, sorry, we haven't voted. All in favour? You can vote. No, well, none of us were, Nick.
Okay, yes.
No, stick your hand up. Okay, because we're the only people that can vote. So we just have to trust our officers were there. Alan was there, that this is a tree. Alan hasn't said it's rubbish, so we're assuming it's all okay. So we can vote on it. Thank you. I always forget the voting, which is very important. Okay, so that's that one. And then the minutes of the meeting held on the 25th of May.
Madam Chairman,
Okay.
May I just,
Yes.
there's an issue that I'd just like to get a little bit more information, even if it's something which has to come back to a later meeting. On that first meeting on the 14th of March, item 42, pharmacy provisions, I was concerned that there seemed to be a rather the issue was made smaller with regards to the potential pharmacy in Sainsbury's at Calcott. I would have thought that that was an eminently sensible place, and I'm absolutely certain that if one was established, that there would be a good number of scripts that would be taken up there. And so therefore, I'm just asking if that can be on the radar and can be pursued further.
Yeah. Vicky, do you want to comment on that?
Yes, we can make a note of that and come back to that.
Sorry, Madam Chairman, I'm having difficulty putting my hand up. That was briefly discussed at that meeting, but there was a representative there from the regional representative of the National Pharmacy. I can't remember the exact name of the organisation, but it's an organisation that looks after the interests of community pharmacies. And he pointed out that the finances of pharmacies at the moment are very stretched, and he suggested that to try and promote another one to replace the one at Sainsbury's and Calcott might jeopardise the finances of nearby pharmacies. So I think we kind of let it drop at that point.
Well, thank you for that update, Councillor Crowe. But yes, I think it is something we need to keep under review. Yeah. Yes.
And I do apologise because I actually had 2 points. The other one was 44 Building Berkshire Together update. I have a concern that we may be slipping down a road that says that Royal Berks has got to be redeveloped on its existing site. And if we do that, then we miss definitely the opportunity, once in a generation opportunity, to do a Great Western as in Swindon, where we get a brand spanking new hospital on a site that is suitable, that's got car parking, that's got bus services, etc. And I have a concern that we're already going in the direction of saying it's going to have to be redevelopment on the existing site, which I think many of us will be aware is mildly cramped.
Okay, thank you for that. I think Councillor McCrae, you want to comment on that?
Yes, there was a report in last week's Reading Chronicle, actually, of a meeting at Wokingham Borough Council who had a presentation on the subject, and the article was saying that the preferred sites are actually Thames Valley Science Park, which is in Wokingham district, kind of partway between junction 11 and 10 on the M4, and Thames Valley Park, which is on the site of the old Sutton Seeds establishment. If any councillors or members can remember where that was. Both of those are on the east side of Reading, which would make life very difficult, I think, for people to get there from West Berkshire, and particularly from those kind of remote from the motorway.
Thank you for that. Obviously, this is something we'll have to keep in touch with. I think Sarah Webster's got the comment. Yes.
I was just going to extend an offer to whether we invite colleagues from the Royal Berkshire to come along to this Health Oversight and Scrutiny Committee to provide an update, and just to reassure the committee that no decisions have been made around future locations. It's still very much an ongoing discussion, and onward engagement will be made with members of this committee and the public and beyond.
But thank you. That would be very useful. And also, I note that there was a visit of members to the site and discussions on site, and maybe in the future that might be something that the new members might participate in, because just to keep us. But thank you. That would be good to that's reassuring to know it's still being discussed. Thank you very much. Now we have the minutes of the meeting held on the 25th of May, which is the brief meeting held at full council when we were appointed. Proposer?
Propose.
Thank you. Seconder? Thank you. And all in favour? Thank you for that. Okay, now we have the actions from the previous minutes. And members are just asked to note these actions. Are there any comments from anybody? Obviously, Councillor McCrow might have some comments to make, or this is where I noted there was a visit to the RBH in relation to its development. We've just had a brief discussion about that. Don't think I had. What is SCAS? Sorry? Ah, right. Thank you. Councillor McCrow.
Yes, members did have a visit to the Royal Berkshire Hospital, but since the membership of the committee has changed, I think 100%, it might be very useful, I think, if another visit was arranged, if that's not too onerous on the hospital. I did find the visit, although I thought I knew the hospital very well from the number of visits I've made for other purposes in the past, I did learn a lot from that visit, and I think that would be very useful.
Thank you very much, Councillor McCrow. Yes, I think we'd all benefit from being updated and from visiting the site. Thank you. Okay, so we move on to item 4, if everybody's happy with that. So any declarations of interest from any members? No, I'm just going to mention at this point that I am a member of the Health Watch Board, and I've raised this before, and I've been told, you know, that's okay from the point of being chairing Health Scrutiny, being on Health Scrutiny. Obviously, the roles of Health Watch and Health Scrutiny do have an overlap, which in fact is quite useful. You know, that we can sort of work together. But obviously, if there was anything being discussed on the board that seemed to conflict a bit with what was going on here, then obviously I would raise it, or if I was involved in anything. But there isn't anything at the moment that I think the council needs to be made aware of, any issues that are conflicting with what the council is doing. Is that okay, Vicky? Have I said enough? Is that
Yes.
Okay? Okay, just checking with Vicky that I've explained that properly, whether I didn't with that. Okay. So we've done that one. Any petitions?
We've not been notified of any in advance of the meeting, Chairman.
Very much. I wonder if people know that they can bring petitions here. I mean, have we had any petitions since we started? Maybe we need to go out and tell people, you know, that we're here. Okay. Right. Do I need to wait for this lady to come back? Okay, we'll just hang on a second. All right. I'll just make sure we move on to get the right papers here. So just to say while we're waiting, obviously we're all, to yourselves that are coming here today, we are all quite new to this scrutiny business and health. So be quite, you know, be patient with us. We might ask some basic questions, but that's what it's all about. You know, and we are here as members of the public, and we're not experts in any way about health issues. Sometimes when papers are produced, you often think to yourself, well, do they think we know more than we do know? Do you know what I mean? That it's difficult to get the tone of a paper right, because obviously we haven't really started. Don't worry. But I was just saying that we're all new, and obviously, so, you know, be patient with questions that we might ask. And also that when papers are being written, I know it's difficult because you know so much about the issues that you're covering, to sort of think about us as lay people and whether we're going to understand, you know. So it's hard, but it's a learning process, I suppose, on both sides, isn't it, really? But one little thing that I have, and obviously it's something everybody mentions, is acronyms. So obviously, wherever you can, please try and explain them. Or it might be useful at the back of the paper just to list so that if something's being missed out, you know, if you have a list of all the acronyms just at the back, you can just quickly flick back rather than stopping and saying, well, what exactly does that mean? Because sometimes you forget, don't you? You should know it and you've seen it before, but you just forget what it means. And it's useful just to have a reference point. So maybe we could just have a standard list of acronyms because they all keep coming up time and time again. Okay, well, thank you very much for that. Right. Okay, so item 6, we're discussing dementia diagnosis, and we welcome our external partners, Sarah Johnson, whom we've introduced previously, dementia service lead, Heather Howells, GP clinical lead, Leila Johnson, Johansson, she's coming.
She's on the screen on your.
She's on the screen.
Yeah.
Oh, she's that lady there. Okay, right. And Teresa Wiles, that is yourself. So Sarah and Heather are going to give us a brief overview based on the paper which we all have in front of us. So thank you very much.
Okay. So I'm just going to talk about what we're going to cover. I'm going to do some. Oh, sorry. Oh, okay. Is that okay? Okay, lovely. I'm just going to do some brief key facts about dementia and its impact, just very, very briefly. A little bit about dementia care services and the memory clinic pathway, the dementia diagnosis rate, what that is and how we're meeting it, a little bit about the national picture, and then also about the West Berkshire picture, and then the identified gaps and improvements, and then areas of good practice. So dementia itself is not a disease, but it's often described as an umbrella term around the loss of memory and other thinking abilities that are severe enough to interfere with everyday life. So most common types of dementia are Alzheimer's, vascular dementia, frontotemporal and Lewy body, and something called mixed dementia, which can be more than. Yeah, there's hundreds under the umbrella term dementia. And it's important to diagnose by subtype because that will have implications for treatment and also planning. So there's no cure for dementia, but medication can slow down the progression. Or where medication isn't indicated, we can look at lifestyle changes like exercise and diet to kind of try and improve somebody's well-being. So symptoms of cognitive impairment, which is what we call it when somebody is starting to show dementia, are things like missing appointments or important events, being overwhelmed by decision-making or planning activities, forgetting words or feeling that they're on the tip of your tongue, forgetting conversations, losing a train of thought, having difficulty understanding complex instructions, and losing your sense of direction, for example, getting lost in your own town or in familiar places. And it's important to note that we can all have that, you know, those at various times when we're distracted by the things. I looked for my phone with my phone in my hand before, you know, kind of when other things are happening, but it's when all of those things are significantly impacting on somebody's life. And that's, you know, when there is issues that maybe need to be explored. So it's important to note that there's no cure for dementia, but that certain medications can slow down its progression. So, for example, people with mild to moderate Alzheimer's disease can benefit from a drug called choline ester inhibitor, which helps the messages, the chemicals that send the messages travelling around the brain. So again, they don't prevent the disease, but they don't prevent it from getting worse, but it can kind of help people to function better. And there's also medications that we can give to people that maybe have other things associated with dementia, like depression or behaviours that challenge maybe, or, you know, kind of anxiety that are part of a dementia, but we can treat those as well. So memory impairment is not a part of normal ageing as well. It's important to say that.
Sorry, memory.
Memory impairment is not a part of normal ageing.
It's not.
No. So so I mean, you get some cognitive changes over time, and as you get older, you're kind of slower and your processing is slower. But when it's the list of things that we talked about earlier, like missing appointments or getting lost in familiar places, that is a more of an indication. Yeah, absolutely. Yeah, occasionally you would expect that with anyone at any age, really. So some of the key facts are 850,000 people in the UK have dementia, and it's set to rise to over 2 million by 2050. 1/3 of people who die with dementia. Dementia was the leading cause of death in 2020. 25% of people in hospital have dementia. People have dementia stay a week on average longer in hospital. 70% of care home residents have dementia, and 1 in 6 people over the age of 80 have a dementia, and often have 3 or more comorbidities, which means they have dementia, but they might also have some physical issues as well, which compounds the kind of, their experience really. There's a greater prevalence of dementia in Black and Asian minorities as well. And dementia is the most feared illness in people over 50. So the cost of dementia is immense to the UK, both personally and for health and social care systems. And it's estimated to cost the UK £26 billion a year. And that includes pressure on increased hospital stays, social services, unpaid carers and the emotional burden of that. And also, as well as said, about people having the comorbidity of other illnesses as well as dementia. So timely and accurate diagnosis is important alongside appropriate support. So I'm just going to cover dementia care services and the memory clinic pathway really briefly. So the NHS Well pathway for dementia includes key guidance for dementia services. So it's looking at diagnosing well, which is in a timely and sensitive manner, living well, which is to provide a care plan to cover needs and support for carers, supporting well, service designed around needs, and dying well as well, planning for the future and being consideration of future wishes. And this enables that care is delivered in a person-centred, compassionate and supportive way that's promoting safety and well-being. And so there's loads of guidance and legislation, key documents that guide the services, including things like the NHS 5-year forward plan. So West Berkshire Memory Services comprises of a consultant psychiatrist. We've got a memory clinic nurse who's a band 7 clinical lead. We've got band 6 memory clinic nurses, 1 band 5 admin support, and also access to psychology and OT and speech and language therapy. So they kind of that's who sits under the memory clinic services. So typically what to expect if somebody comes in for a initial assessment, they're seen by a specialist healthcare professional. They undertake a set of memory assessments. So things like the Adam Brooks, which is a series of questions which will look at how somebody's sort of cognitively functioning and how they're processing information. Often we ask for imaging. This is where an MRI head scan is appropriate. And then really detailed history taking, sort of family history of difficulties, kind of onset. It's not just within the last few weeks, but, months that it helps set up this picture. Because it's important to rule out other presenting concerns like a depression or physical health issues. So a blood test and a physical health check is also important before referral to the memory clinic. So an initial assessment itself can take quite a long time because you're gathering all this information. And then interviews with family, next of kin and friends who know the person well is also really important. And it's also important to talk about mild cognitive impairment being different from a dementia. So a mild cognitive impairment is thought of as a stage between normal aging and dementia. And so since it's not a dementia, the implications that mild cognitive impairment is typically not significant enough to impact on your daily life. So as we're talking, you can have some issues, but they're in the milder range. But it's important to mention that because when people are referred to the memory clinic, it could be that they've got a mild cognitive impairment. So they go through all the assessments, but they don't get that the dementia diagnosis at the end of it. And we do something called watchful waiting, where people will come back a year to see if there's any changes. Is there any questions about that so far? No, start. Okay.
Lots of information.
Yes, absolutely. So the national picture. So we look at something called the dementia diagnosis rate. So the dementia 65 plus estimates the diagnosis is an estimated diagnosis rate indicator, which compares the number of people thought to have a dementia with the number of people diagnosed with the dementia dementia age 65 and over. And the target for it is at least 2/3, 66.7% of people with dementia to be diagnosed. So that's kind of the targets that we aim to achieve. And then key areas to support the dementia diagnosis rate are stakeholder and public education to highlight the importance of timely diagnosis, reduction of fear and stigma, primary care as well to identify those who present with concerns with memory, and that they're referred in a timely manner to the memory clinics. The acute trusts are also important because 25% of patients in hospital from unplanned admissions have dementia, and also as well to look at care home residents and then referral onto the assessment services. So GPs screen people attending for long-term conditions can also be reviewed for dementia. They can GPs identify early cognitive decline, refer to the memory clinic, diagnose patients who are living in care homes. So those ones that it's really obvious there is a dementia and they wouldn't benefit from coming into the memory clinic service can be diagnosed by the GPs. The GPs ensure correct coding following the diagnosis and then work with the primary care networks to improve the diagnosis rate. So some of the challenges of that is that the national ambition is quite hard to achieve because it's based on estimated dementia prevalence, and the latter is dynamic and changes month by month based on the GP population. So deaths in older population, people turning 65 in that month, or people that are moving in and out of areas. So therefore, the dementia diagnosis monthly rate needs to exceed the number of losses. So there's always a push-pull with that. So the West Berkshire picture is that our diagnosis rate is increasing. So at the last national dementia rate report, we'd gone from 3,888 to 4,013. So we're going in the right direction. And then system-wide, we are comparable with Oxford and Buckinghamshire in that the diagnosis rate for West Berkshire is currently 59.7%, which is the highest in kind of our region. So there are improvements. So just a little bit about our waiting times. So the waiting times are above the national target. So currently we've got an average waiting time of 21 weeks, and the number of people waiting for their first assessment is 176 people. And that can be based on many reasons. So it may be that there's some patient reasons why somebody hasn't come into the memory clinic. They might be offered an appointment and go to hospital. There's, kind of people that might not come for their appointment because they're unwell on the day. So it's quite a dynamic picture, and the figures are really sensitive to movements in that, really. So currently for West Berkshire, we've got support for those people that are waiting longer on the list. So we send out a letter to the referral and the patient with an estimated time of when they're likely to be seen. We link to the voluntary sector in the Alzheimer's Society, and then also kind of bridge to social services. And then if somebody's in real crisis while they're waiting for their memory clinic appointment, then they're often can be seen by the home treatment team or the community mental health team to kind of hold them whilst they're waiting for those assessments. And then we've also got psychology support for carers, and as well make sure that carers have an assessment in their own right. So there are gaps, and a lot of this had to do with staffing, and also COVID had a big impact because our services were paused, but the referrals were still coming in thick and fast. And in the report as well, it showed that 1 month we had 80 referrals coming in. So that's kind of a lot really and once the referral rate was exceeding the people that were being seen, it's sort of, so at the moment we've got some targeted work, identifying practices that might have a lower diagnosis rate. We've got a production worker who looks at our records compared to the GP records and identifies where there might be a gap. There's some new reporting on harder to reach communities and evidence to show that people in more deprived areas have a lower diagnosis rate. And although we're not particularly in a deprived area, there are pockets of West Berkshire that might fall into that. And also as well, that kind of rural areas also have a lower diagnosis rate. So the memory clinic service itself has some quality improvements underway. targeting the waiting list. So we're looking at some extra consultant time, and we've also got some kind of shared resources with the other localities. So another consultant is going to come and do some more initial assessments with the team, and also as well we've got a specialty doctor post, which is just going to go out to advert as well to kind of help really target the waiting list. And that we're also part of the Royal College of Psychiatry National Standards, something called MSNAP, which is the Memory Service National Accreditation Programme, which kind of ensures certain standards as well, that we've got, you know, quality, that we don't want to just be a production line of people coming in and being diagnosed, that they get support for kind of post-diagnosis support, and, you know, that they're seen in a sensitive way, because it's a really devastating diagnosis for people, really. So nationally, the national dementia audit showed that waiting times in general, sort of across the country, had increased from 13 weeks up to 17 weeks. So there's a national picture, and I think COVID has really impacted on all of that. There's often 47% of patients that come into the memory clinic wait for MRI scans. So if there's a wait for the MRI scan, then they can't be diagnosed. So then that also has an impact on the waiting list. And then some of our areas of good practice, if we've got good links with the voluntary sector, we run an understanding dementia course, which we do online and also virtually. We've got something called a cognitive stimulation therapy program, which we also offer online and virtually. We've got good links with the Younger Person with Dementia charity. People that come in under 65, we generally try and see them a bit quicker, because it might be indicating that there are other things happening there. And we've got really good sort of links with the carers set up as well. So we've got good carer support. And then some of the sort of key messages really are that our referral rate continues to increase, which does impact on the waiting time. So demand is higher than resource. Also that dementia is everybody's business. So that we want to increase the knowledge in the community with things like the Mental Health Awareness Week, Carers Week, that, you know, we all should be talking about dementia, and it's kind of highlighting that to reduce stigma. There's some work looking at dementia-friendly practices, and some discussion about this initiative being funded in West Berkshire as well. And also sort of recognition of care planning, that once somebody has a dementia or a dementia diagnosis, there's so much more to that, you know, kind of this, all the aftercare with that, really. So I don't think there's anything else to add. Okay. Thank you.
Okay, right. Well, that's very thorough.
Okay.
So a lot of information. Obviously, you've described the dementia pathway to us, and you've said a bit about the support that's on offer. So people don't have to wait for a diagnosis before the support kicks in.
Yeah, so we can link people with things like the Alzheimer's Society, but we have to be a bit careful that if somebody's been referred to the memory clinic, that we kind of sensitively pass them to the Alzheimer's Society, because that person hasn't got a diagnosis and they might be feeling a bit unsure about that. So, you know, it is kind of making some decisions about the best places to support people.
And the issue of the memory clinic. So they can't be properly diagnosed until they've been referred to this detailed assessment at the memory clinic. But I think I saw, looking at the notes somewhere, it looked as though if the GP, an experienced GP, thinks this person is heading down the dementia pathway, they're probably right. So then why do they have to have this extremely long waiting list to get to the memory clinic, really? It just, you know.
So there are some people that GPs, we know it's not worth them going to the memory clinic and having that assessment. So people with advanced dementia that haven't had a diagnosis yet, for example, in a care home setting, there is probably not a significant value for them going to the memory clinic. And there is a tool called the Diadem tool, which GPs can use and other health practitioners in a care home setting to diagnose dementia. And so that's one of the things that we're looking at increasing the use of in our and the knowledge of with our GPs to help improve that. in younger people, there's definitely a benefit to having an assessment and with a specialist, and to probably having a scan. And as GPs, we can't organise a scan, an MRI head scan. So it would necessitate a referral to a memory assessment clinic. I suppose the other thing just to add about that care around patients, in that most GP practices now have care teams or care navigators. And quite often what we'll do if we've referred somebody off for an assessment whilst they're waiting is get our care navigators and our care teams involved. They can look at local support. They can look at any equipment or other things that might be needed to support family members and patients in the community. So most GP practices through the network DES now have those teams within them.
And do you have any inkling of why we are at the bottom of the league table as regards diagnosis here? Is it semi-study? Because is the reluctant, I mean, I imagine there's a reluctance of people to come forward to actually get this diagnosis, because obviously, as you said, it's quite daunting, and it probably means your life, you can see your life sort of narrowing out a little bit, really. So maybe it needs better education, or do we know why the figures are bad?
I think, as Sarah says, it's multifactorial. So I think we do need to reduce stigma. We need to encourage people to come, because we know that an early diagnosis is beneficial. So we need to do that not just in primary and secondary care. We need to do that in our communities. We need to increase education about what dementia is. We need to encourage people to attend for a memory assessment and take some of that fear and stigma away. I think in terms of our memory assessment waiting times, COVID had a significant impact. So these were vulnerable people with multiple comorbidities often, who were shielding and who didn't want to attend or couldn't attend, therefore, a hospital-based service. So the waiting times increased. And then,
this would affect other areas as well, not just West Berkshire.
Yeah, that would have, absolutely. And then our memory assessment service in West Berks has had some significant staffing issues, which they have worked really hard to address. But I think the staffing issues and the radiology issues with the wait for MRIs is national. It's not just a West Berks picture. So I think they're working hard to mitigate that, as Sarah said. But yeah, I think it's all of that combined, really, which has put pressure on the service.
So it doesn't sort of really explain why West Berkshire is having a problem, does it? Because if all those issues you've mentioned are national issues, it's or is the staffing issue particularly bad here for all those other things, the house prices and stuff like that? Is that?
I think the staffing issue at the memory assessment service in West Berks was a particular issue. I think the others are sort of national drivers, but the staffing issue was something that was quite significant.
Thank you. Yes. Yes, I'm just on the same subject. Would I be right to say the diagnosis rate is not related really to the waiting times? Because I'm guessing that if the waiting time is, say, 19 weeks, then the rate is not related. Is that true, or does it link? I'm kind of started trying to wrestle with that, and I was then going to just ask you a follow-up question on the causes of the diagnosis rates being lower than we'd like, over and above what you've just said. I wondered whether you made a comment. Sorry, you made a comment, I think, about GP records. I wasn't quite clear what that meant. Is that to do with getting insight from somebody who's gone to the GP and getting that turned into early diagnosis? Is that what that meant?
So the rate is based on coded data. So it's based on, the data is extracted from general practice records. And so what we need to ensure in general practice is that we've coded it correctly. And what we saw when we did this piece of work that looked at improving the dementia diagnosis rate was there were some discrepancies in GP coding. So there were people who had a diagnosis of dementia but had been coded as mild cognitive impairment. That doesn't allow them to be added to the dementia diagnosis rate. And there were also some missed codings or some letters that hadn't been received from secondary care and therefore weren't put onto the primary care records. So we've done a really good piece of work, as Sarah said, with the health production team to make sure that we're looking at monthly the difference between what the memory assessment service knows, how many people they've diagnosed, and how many people are recorded in primary care. It's a data issue. And I think you're right about the DDR. I think waiting times may have a small element to play. You know, the more people you can diagnose and get through the system, the higher your DDR, presumably, but also it's about making sure that we are diagnosing those in care homes, that we are recognising that people, or encouraging people to come forward for a diagnosis. And I guess that's where the national drivers would sit to help us push forward this DDR rate. And although we are slightly lower, actually, if you compare us, as Sarah said, to the rest of Buckinghamshire and Oxfordshire, we're actually doing better. So I think very few areas in the country are meeting the DDR.
Yeah, thank you. I'm interested in how you look at other parts of the country and how they're doing and how you communicate basically with other health authorities. What I'm thinking of also is we came across this term rurality, which I think is obviously implying, you know, in rural communities, it can sometimes, those can be hard to reach communities. And I'm thinking, you know, do you, for example, look at a county or an area like Northumberland, which is very rural, and they have very isolated small communities, and how they are comparing with their diagnosis, dementia diagnosis, compared to us, and then if there are any lessons we can learn from what they're doing. Thanks.
Oh, yeah. So we often have kind of national kind of forums with other memory services, and we can kind of see and then kind of share learning with that. So there's quite a few of those that happen that kind of all of us are involved in. The national diagnosis rate is a document that's sent out every 2 or 3 months. So and then we can look at the kind of league table there. And as Heather said, we're not actually we're not an outlier at all. But yeah, there's a new kind of reporting tool which is looking at the harder to reach places like the kind of more rural areas. So I think there will be a piece of work looking at that. But, you know, we know ourselves that we kind of put things in GP surgeries and into the, you know, kind of community hubs where people are going and kind of advertising and promoting and asking people to come, you know, for diagnosis earlier, or at least kind of speaking to somebody about kind of that they might be having issues with their memory. And does that kind of...
Yeah, and I think we share best practice. So we sit on a Southeast regional meeting, and there's often kind of sharing of best practice between other areas, things that have worked in their area. Because you're right, there are sometimes strategies and things that people use and different enhanced services that encourage diagnosis in a different way. So I guess we learn from that when we can.
Okay. May I ask one more supplementary question? And that really relates to, now this is embarrassing because I've forgotten what I was going to say. What was it? Yes, I'll come back if I may. It's just gone out of my head.
Okay. Yeah, I was wondering about the awareness of GPs and staff, you know, their abilities to diagnose. Is there training issues around that, or the pockets? Is it better in some practices than others? Do you notice a distinction between different health practices where you can see that there's GPs that are quite skilled, or practice nurses or other staff or whatever, and that may be not so skilled in others?
Yeah, so I think that's what Sarah alluded to. When we look at those practices that have lower DDR rates, it makes us wonder, is that because patients aren't coming forward? Is it because GPs aren't referring them? Or is it just because of their population? So, you know, that I would probably expect, I don't know, but maybe our inner city practices have a younger population of patients, or and perhaps therefore less likely to refer onwards. I think we do regular GP education. What happened, I suppose the other thing we didn't really mention was that we did change the care pathway. So to try and relieve some of the pressure on the memory assessment services, they used to do an annual review on everybody with dementia in their service. And there's just no way that a small memory assessment service can do that. So the annual review has come out to primary care, and GPs are now tasked to do that. So I think most practices and most GPs have the skills and knowledge to do this and to do it well. And I'm not sure that is the thing that's limiting this. I'm not sure that all GPs have the knowledge and skills to happily use the diadem and diagnose in care homes. And that's something that we're trying to work on rolling out. Yeah, in our area. Yeah, it would be good.
Thanks very much. You mentioned earlier, I think, Heather, that obviously COVID prevented people coming to memory clinics. So had we not had COVID, you can imagine a large cohort of people would have gone to a memory clinic, had an early diagnosis of dementia. Now that has not been possible. So in your view, is it we're looking at a big increase now of people that have got, if I can put it this way, well-established dementia that might have been, that disease, the dementia process could have been slowed down had they been seen. And if there is an increase in numbers, is there any way we can mitigate that? Can we put more resource in, or what's your view on that? Thanks.
Do you want me to pick up the resource question? So yeah, certainly one of the things we've been doing internally within the trust is looking at the rates of referral and the waiting times across the whole of Berkshire, and being able to flex and move some of our resource to help support where the waiting times are longer. So that's here, but we also have a team in the east that have similar lengthy waiting times, but often real direct correlation between referral activity. So for example, October last year, there were 78 referrals for here compared to 45 in Reading. And that probably sort of relates to Heather's comment. You have quite different populations across Berkshire West, and really thinking about how do we flex our resource to get the maximum benefit. I think we have had some significant staff gaps, which we've been trying to recruit, and not unlike every other trust in the country, being able to recruit skilled memory clinic nurses is a real challenge. So our real focus as an organisation is trying to retain our nurses and develop some career pathways. So quite a lot of apprenticeship nursing roles now, working with lots of new roles. So we've got workers in GP practice called R's, or funded through R's, and they're mental health practitioners, and they're really supporting GP colleagues with on-the-day demand and really trying to help people get into the right pathway quicker. But with all of these new roles, there is a risk that the core services staff move out of those into these new roles that are really quite exciting. Lots of breaking new ground, working in different ways. So there's lots of benefits to that to our practice populations, but actually it does cause some challenges often in our core functions. And I think memory clinic historically has been one of those teams, as are our community mental health teams for adults.
But I was just going to say, it sounds as though there's a lot of work that needs to be done on sort of promoting the exciting prospects in working in this field, because the elderly and dementia, it sounds sort of heavy and because I trained as a nurse many years ago, and I can remember a geriatrician saying that this has a very poor press, working with the elderly, yet it's really one of the most important aspects of the work you can do. So it's probably the sort of just trying to give it a different, I can't think of the right word, but making it more exciting to join this type of work. Anyway, we've got, I think it's Layla up on the screen. Was a comment?
Hi, yes, thanks very much. I just wanted to sort of sketch out the future a little bit when we talk about resources and addressing the point that you just made. So we just secured some additional resources to come into my team to start setting up a partnership board for Berkshire West, and to also develop a BOB strategy, ICB strategy around the dementia pathways. And I think one of our ambitions is that we work more closely with public health. There's lots of quite exciting new research coming out around how we keep ourselves healthy. So what Sarah alluded to at the beginning is that having dementia is not a natural part of aging. So there's some work to do around how do we as a population stay healthy so we don't develop dementia. We also think there's opportunities around some of the people, the 25% that end up in acute pathways, that we might be able to do some work around those individuals in particular, that we might divert them away from those hospital pathways, and some more work in care homes around behaviours that challenge, how we might put some more resource into those care homes for those patients to have better experiences as the dementia advances. So those are some of the sort of new elements that will be developed over the next year or so.
That sounds good. Thank you for that. I think Councillor Jeffrey. Yeah.
Thank you. I'm going to probably sound a slightly discordant note, and I don't want it to be discordant, but it is a very serious question. If you look at page 23, Dementia the Long-Term Plan, I don't think there's one solid target in there. We will go further in improving the care we provide to provide people with dementia delirium, whether they are in hospital or at home. And you look at all of them, and they're all aspirations, hopes, intentions, but there's nothing hard against it that says, we will get the referral rate down from 61% to 55% or whatever. I think there is the people that are sitting on this side of the chamber will know this is what we would call the Jeff Brooks question, which is always bringing everything down to pounds, shillings and pence, but pounds, shillings and pence does actually matter, and hard numbers do actually matter. If that is the long-term plan, and it's we will go further, we will improve, we will transform, lovely words, how are we going to actually see them happen in practice, and who is setting some concrete targets in there that we're going to see X number of people or Y number of people, or we're actually going to be the best in the country or in the area or whatever it might be. So can you put some gritty bits into this, please?
So the target that we work to is the dementia diagnosis rate, which is a fairly blunt tool, as I think as Sarah explained, that it recognises that in a population, it estimates how many of that population you would expect to have dementia, and then the aim is that 2/3 of those have that diagnosis recorded. So when I look at the Bob picture, Berkshire West is the highest performing of those areas, and actually in the southeast region there are only 3 areas that have achieved that target at the end of March 23, but the national average for England is 63%, and for Berkshire West it's 62.8, and in the southeast region it's 61.5. So, and that's been a 2% increase is over the last year, is actually quite a significant improvement. It might not feel like it because it's a very small number, but in terms of that progress, that has been significant, and we will continue to build on that. And I think in the paper that Sarah and Heather submitted, there's quite a lot of new medications coming online, different treatment pathways, but actually over time, you would hope would start to reduce some of that sense of fear and dread of receiving this diagnosis, and may encourage more people to seek help earlier. So that's the measure that we have at the moment. And we also have our waiting time metrics, and we are busy working as an organisation and across systems to see how we can get that closer to the target that we want to deliver, which is 6 weeks.
And may I ask how much of this is down to good old-fashioned staffing and the numbers of people that you've got? Have you got the right number of people at the moment, or are you substantially down?
I think we are recruited, and we've got some roles that are out to recruit. So we've got a medic role that will really help with that confirmed diagnosis. We have over the last period of time moved resource across the trust, so across Berkshire, to help West Berkshire particularly because of the higher referral rate. But it's a constantly moving feat, and gaps in staffing I think are a challenge. Workforce in the NHS as it is in social care is one of our biggest risks. Primary care, I don't think it's any better, Heather. So really trying to work together on that retention piece, because we can keep bringing people in. If we lose people early on in their career to other organisations or leaving the NHS or social care, it takes another 3 or 5 years to get that workforce back through.
Chairman, you said West Berkshire. Did you mean Berkshire West? Because West Berkshire is this council and Berkshire West is us and Reading and Wokingham, I think, isn't it?
Yeah, so when I was giving the dementia diagnosis rate, it was Berkshire West.
Do you want to comment on this, Leila?
Yes. Yes. I just wanted to say that obviously this is a national programme, so the KPIs are set at the national level that we have to work to. As Teresa alluded to, there are targets around the memory serves that are set locally, so we can keep an eye on how quick we have the through flow within the service. It's just worth bearing in mind that within the national programme, there's a number of different quality initiatives as well that sits in a dementia pathway. So what patients will be telling us, it's all very well having a diagnosis, what happens afterwards. So that, how do we personalise care? How do we care for people and the carers that look after them? So there's a number of initiatives that we will be looking at within Berkshire West and indeed across Bob ICB as a whole around how do we improve the experience of patients within this pathway as well. So it's not just simply about numbers, it's also about patient experience and how you live well with dementia and the end stages of dementia.
So do you have a system for getting feedback from patients and probably their carers so that you know how you're doing as regards?
Yeah, we've got an initiative called I Want Great Care, which is when somebody comes in for an appointment or they're seen by a clinician, there's a sort of satisfaction questionnaire that they can fill in and they can provide comments as well. And then kind of locally as well, each of the services kind of has their own way of kind of just asking people, you know, kind of what the experience of the service was. Yeah.
Sorry, I just had a couple of questions. One was, I think you said at the beginning, 850,000 people either would have it or were diagnosed with it, going up to 2 million by 2050. I was just wondering, could you just explain what drives that growth? Because that's quite a big difference from now till 2050. Please, thank you.
Again, that's kind of based on an aging population. So we are kind of aging, and as we age, we're more likely to kind of have a dementia as well. So it's kind of based on those sort of prevalence of we're just getting older.
Okay, and then the other one was, is the care navigator something that's available in most practices? And would the average person not necessarily know there was one? Are they kind of working under the radar effectively in the GP practice, or are they only in some places?
I think they're in most practices. It's part of the primary care network enhanced service, so that they were funded similar to the R's mental health practitioners that Teresa were talking about, so that practices could receive funding to have care navigators and care coordinators within their practice. I think most practices have them. They sit almost in the same umbrella as the social prescribers. And I think what we're trying to do as a group of practices is, and as primary care, is to get out that more and more. And one of the changes in the new GP contract is to really promote the use of those services to patients, so that patients could ring and directly ask to be referred into them. Certainly in my practice, we're holding an event with our patient participation group to promote them in September, because I think you're right, there are a number of services that sit in primary care now that probably most people are not fully aware of and how to access them. But that's also one of the key roles of our reception staff, who are being much better trained in trying to triage on the phone where people would most appropriately go. So you may have historically been directed straight to your general practitioner, whereas now actually, if we take a brief history on the phone, we can say, oh, actually it's our care team that would be able to help with equipment or care needs. So I think there's greater knowledge, but probably we could do with promoting that more.
Great, thank you. And sorry, just the last one was did you say the GPs do a test? And is it potentially similar or different to the ones in the care home? So in other words, if somebody goes into the GP and hints that they've got a problem, does the GP do something? And is it presumably standard that what they do?
Yeah, there's a standard test. It's not anywhere near as detailed as the test you'd get in a memory assessment service, but there is a standard test, the GP cog that we do, and a set of blood tests, because sometimes there are certain blood abnormalities which could help reduce memory function. And so we need to make sure that all of those tests are done before we can refer on to the memory assessment service. So there's a standard set of tests that GPs do.
Thank you. Just a couple of brief questions. You mentioned prevention. Now, clearly, prevention is far better than trying to deal with cures. It's also extremely difficult to measure. My colleague Owen mentioned about numbers and costs and things like that, and we're all familiar with, how health service metrics, work on operations, success of operations and that sort of thing. But prevention, I know, is very difficult to measure, but it's extremely powerful tool. And it sounded like you have, or you're aware of, some quite exciting potential developments possibly in that field. And I would think that's a really good area to focus on. But if you do focus on it, try and measure what your outcomes are, because you'll have questions, sort of saying, okay, we've spent X amount on this. What's the outcome? And it is so difficult to measure prevention, but that's quite exciting. Also, the other thing that struck me on a personal note is my father's in a care home at the moment. And a lot of the care home staff are, the people that look after the residents are extremely motivated, and I've been immensely impressed actually in my father's care home. Is there a training pathway, or could they be trained up in some way to act as sort of auxiliaries or in some capacity to help with diagnosis, or even possibly help with treatment? Because I know for a fact there would be a lot of very willing people that would be interested possibly in training to do something, if that was something that would help from the medical point of view. Thanks.
I think often their role is in recognition that somebody may have a dementia, and you're right, they often know these patients much better than we do, coming in just on a weekly basis if there's something going awry. And there is a program called Dear GP, which does that. Just that care home staff are trained to recognise when somebody may have a developing dementia or dementia, and alert the GP to that, so that then the diagnosis then takes place. So I think there has been quite a lot of training for care home staff around dementia, and I think you're right, that's vital and really important. And I think on the health promotion in general, we use the phrase, what's good for the heart's good for the head. So we know a lot more, don't we, about cardiovascular protection. We know, we should be exercising, not smoking, drinking and reducing our drinking. And all of those things that are good for our hearts are good for our brains. And that's what we really need to be promoting. But you're right, how we figure out the reduction that has, it is difficult, but it's vital. I think you're right.
And even, I was just going to say, even just this morning, there was kind of on the news about the shingles vaccine, about how in Wales they had the shingles vaccines for people that were born at a certain year. So if you were born, I think before 1935, you couldn't have it. But if you were born after, you could have the shingles vaccine. And what they found was there were pockets of reduction of dementia in people who had given the vaccine. Yeah, so very, very small, but significant.
I just wondered if Catherine, who's our senior program officer for public health, whether she wants to comment on the preventative side, or what's happening.
So really just to pick up from Dr. Howells. So in my role, one of my roles in the public health and wellbeing team is to commission the NHS Health Checks programme. We have a universal programme delivered in our primary care practices, and we're in the process of commissioning a targeted outreach programme. But that NHS health checks programme is a CVD prevention and early detection programme, but in line with what Dr. Howells mentioned. So staff who are delivering that programme are also trained to give that message: what is good for your heart is also good for your health, for your head. So absolutely, our staff are trained, and that's a nationally mandated programme. It's a nationally governed programme, and that is now a firmly established part of the NHS health check programme, is to share those messages with our residents who are accessing that programme. So that it's the universal for residents who are aged 40 to 74 without pre-existing cardiovascular conditions.
Is a memory question, is that part of health checks?
It's not currently, although that can be part, Sorry, it keeps going, it keeps flicking off. Okay. Yeah, so that as part of the discussions that can be given to a patient attending for an NHS health check about how to, if they've got concerns about their memory, about what they might do about that, so that, be referring to a GP and to discuss that further.
I mean, it's sort of the whole business about, people being aware of, and not frightened of dementia, but knowing that early diagnosis means they can slow it down and maybe even just stop it, possibly, who knows, I mean, is there anything that the council, and maybe combined with Health Watch, can do, maybe in public campaigns, or maybe a big public meeting? I'm just wondering, what can we do as regards, people out there that are meant to be getting messages out to the public? I don't know whether Paul wants to comment here or anything, or we've got Health Watch coming in later, or maybe Fiona wants to comment now. What could we do? Could we be planning some event to actually sort of get the message out and make people less frightened, make them more aware, talk about dementia friendly? I mean, we've had dementia friendly campaigns. I don't know whether we still got the officer who did dementia friendly courses. So, but she came out and talked to the town council, didn't she? I can't even remember her name now. About what it's like to have dementia and how businesses need to actually be aware, and about their colour schemes, and and what people with dementia see. If they go into a public toilet or something, if something's black, they see it was quite a lot of interesting points about what life is like. And I think we had something at Shaw House not long ago where we went and sort of walked through you did a sort of dementia trail somewhere. It gave you a feeling of having dementia.
And there's something called the dementia bus as well, which kind of just, that's a really...
It was the bus I remember. So more of that sort of thing. But that was slightly, I found the bus a bit odd, actually. But sort of, you need to have the awareness, but you also don't want to frighten people. You also want to get the preventative message across.
I was going to make that point that we do. I don't want to minimize it. There's a lot of activity that goes on, a lot of campaigns, particularly through the public health and colleagues, of course, across the health system. So there's work going on. Of course, your challenge, Martha, is can we do more of it? We can always do more of it. I suppose I'm mindful that the Health and Wellbeing Board might be a place where we could have that conversation about proactive work. Obviously, Alan is, Councillor McCrow is the chair of that now. And I think I'm going to ping Lila an email in the background here, because I think that strategic leadership piece across the system has been a bit quiet for a while. We need to get that back up and running, as she was describing, and start talking to each other more about how collectively are we going to target our energies. So we'll take that challenge, Martin, and see what we can do about it.
We've got Alan listening in there, so hopefully he's taking his Health and Wellbeing Board. And also the issue about inequalities, I think, is a big one, which is just so big. And I'm sure lack of people coming forward, lack of information, fear, I don't know, the links between exercise, all those things are going to be greater. So outreach work into certain areas, probably, I don't know, which is probably expensive, I know. And just lastly, from me, I don't know whether you're aware of, there's a suggestion. Well, I think it's a strong suggestion that there's some a little school closing on Donington on Love Lane, due to sort of, there's a new development nearby, a new school being provided in Donington Heights. And that building is being put forward as a possible dementia centre. And Green and Trust have said they will fund, and I think Fair Close are interested. And it just means the council getting its act together to sort of sort out land ownership. And I think that's an ongoing, you know about that, Paul, do you? So I mean, that sounds to me like it could be a good resource, you know, sort of, I don't know, one-stop shop for dementia. I'm not quite sure what's in mind. Do you know any more about that, Paul?
All I would say is that we have had a few conversations with Fair Close and with the Green Trust, and we'll keep having a conversation. So I can't give you loads of detail, but yeah, we are linked into both of those groups.
Okay. I believe from the parish council who've been lobbying me, there's a deadline on getting the land, all the bits sorted out, because it's, in order to get their funding, they need to sort of have things sorted within, I don't know, it's got to be completed in the next year or so or something, or next 2 years. I don't know. I mean, anyway, but that's an ongoing thing, but that obviously would be a good resource locally, wouldn't it? Have members got any further questions? No. Anybody up there? No, can't see any hands going up. So this is just to say that we haven't got any recommendations associated with the report. So we're asked to note the report and consider if we wish to see any further scrutiny work on anything we've discussed today. Do you want any issues going forward you think need further scrutiny? Sort of maybe outreach or public campaigns or something? Yes, no?
Yeah, I was just wondering if we can have a follow-up at some stage, because I think that would be really helpful just to sort of see where we are. Because, I mean, just intuitively, my feeling is this year is probably the first year I feel more like pre-COVID than the whole period. You know, last year was a bit strange. Obviously, the 2 years before were very odd. So, you know, obviously there's been a bit of a delay. So it really would be good to get you back for a follow-up at some stage. Yeah.
Yeah, that would be good. Yes, because it's such a big issue, and just looking at the numbers and everything. Yeah, that would be great. Thanks for that, Nigel. Thank you. Well, thank you very much to our presenters. That was really, really useful. Lots of information, and I think I feel I know a bit more, and I'm sure my colleagues do as well. So so thank you for coming all this way in person, and you're very welcome to stay if you wish, but you probably don't. Learn all about diabetes. Okay. Thank you very much. Lovely to see you. Thank you very much. See you again sometime. Thank you. Bye. Bye-bye. Bye. Sorry.
I'll turn this on, particularly because it's about this. Most people really do not comprehend how these perishing things work. And so they will tell you, they'll make a really important speech and convey a lot of information. And the only way you can do it is by speaking up to it or what.
I will do that. Thank you, Owen. Thank you. Okay, right. We're moving off to our other item for consideration today, which is diabetes service. And we've got my little list here. Oh, where are we? Oh, sorry, I'm looking too far down. We've got Dr. Heike Veltman, who's up there on the screen. She's put her hand up. GP Joint Chair Bob, Integrated Cardiac Delivery Network Manager and lead for CVD, cardiovascular disease, Chair of Berkshire West Long-Term Conditions Programme Board. That's a very long title. And we have Sarah Bow, Bob, Integrated Cardiac Delivery Network Manager and oversight of long-term conditions across West Berkshire. So would you... Sorry? What did I say? I do beg your pardon. Right. Would you like to give us an overview? Thank you, between you.
Thank you. And thank you very much for the opportunity of speaking. As As you mentioned, Chair, I'm a local GP and actually filling in for Dr. Balaji, who is the usual diabetes lead for Berkshire West and for Bob. But I'll try and do due diligence with my long-term conditions hat on. The other thing, if you don't mind, just ahead of starting, I'm actually in surgery today, and my surgery is due to start at 3:30, so I might need to step out, and then Sarah could conclude any questions that you may have at that point. And then without further ado, I'll share my slides, if that will work with you, because I've reordered the slide deck a little bit. Here we go. Are you able to see that all right? Yes? Excellent. Thank you. So the purpose of today's review is to give you an overview of the position that we have in West Berks for our patients with diabetes and what current services are available. I will be focusing on type 2 diabetes. That is by far the most common type of diabetes. And the other very important thing about type 2 diabetes is just how important lifestyle measures are, that it can not only improve control, it can even reverse diabetes. So there's real opportunity if we get it right. This slide just shows the current population in West Berks. So we have 4 PCNs, a total patient population of about 556,000. And within that, diabetes patients numbering about 6,700. So then along came COVID, and as that pandemic, it affected all aspects of life, of health and general well-being. And diabetes was no exception to that rule. So what happened in that time during in and out of lockdown? Patients became less active. The government forced you to say, stay indoors, keep safe. Our eating habits changed. As a result of this, there was some general deconditioning of conditions. There was disruption in routine care and overall late presentations of problems. Conclusion of that was poorer control of your diabetes and more diabetics. So currently, the prevalence that we have of diabetes in the areas, so the first part of the table tells us pre-pandemic, and the latter part is December 22. And as you can see there, it followed form in that there's an increase in prevalence in all the PCNs. And I would venture to say that the overall increase in West Berks was higher than that across Bob. So what I'd like to do is just take you through, how does this work? You know, how do we go about diabetes? And the answer to that is we start with pre-diabetes, prevention. So we want to detect it before you become diabetic. And we've been really fortunate in Berkshire West in that we've invested in a locally commissioned service for several years now. That started way before the pandemic. So this incentivizes all practices that wishes to sign up to it to try and identify people at higher risk of developing diabetes, asking them inviting them into the practice to have a review. And on the right-hand side here, you can see what a review entails. So your set blood tests, you know, cholesterol, diabetes, what are your kidneys doing? And then a set of measurable things that's within our gift to change, the weight, your waist circumference, blood pressure, and then lifestyle matters at the bottom there. In your review and primary care setting, a care plan is drawn up with the patient. And this is so important because we're involving the patient in how they are planning on addressing it. If you've never been to the gym, you're not going to suddenly start going to the gym. So involving the patient in how they wish to address this. And part of that review is the offer of referring them to the diabetes prevention program. This is a national diabetes prevention program, and I would venture to attribute our success in Berkshire West to that enhanced service that has been in place for several years. If you see here how the referral rate to this program is much higher in Berkshire West as compared to other areas. And if I may just talk you through the patient pathway. It's quite a busy slide, but if you bear with me, just to get an overview of how the process is and what is to be expected. So within Berkshire West, we proactively identify patients at a higher risk of developing diabetes, so pre-diabetes. You are invited to the practice to have your test done, and at each point of contact, the patient has the option to say no, thank you. But if the patient does accept our offer, has the test. Importantly, part of that annual review is coding. I heard Heather speaking of coding quite a bit there. Absolutely essential, because once the patient is coded in primary care as being pre-diabetic, we do a yearly review, a yearly recall. And in that yearly recall, it might be that you've attained your goals that you set in your care plan and your blood sugar levels are back within normal range. Or you continue to be quite stable in that pre-diabetic state, or you may have progressed on to become diabetic. This is important. So this is detecting diabetes before you become symptomatic. So if you were in that group and become diabetic, now we recode you within primary care that you are indeed diabetic. And as you can imagine, you can just present being diabetic in the first place. So that's how you can get to that bubble. Now, the assessment in your first diabetes outpatient clinic is talking about your 8 care processes. I'll be giving you some more detail about what that entails in the next slide. In that appointment, we do a cardiovascular risk assessment. We do a referral to a structured education program. We talk about medications, the pros and the cons, and what can you do from a lifestyle perspective. And then, importantly, also a referral for that annual retinopathy screen. The patient is recalled yearly. So in your yearly recall, it's a 2-step process. The first step is data gathering. So all the tests and the measurements that need doing, and that is sent to the patient. So the second part of the appointment is the patient coming with the benefit of their test results to speak to a clinician. At that clinician appointment, now the patient is, understands their numbers, and if they've got more questions as to which part can be made better, but importantly is assessing what is important to the patient at that stage, because that's going to make the biggest impact on how they approach their diabetes. I'd like to draw your attention to this bottom statement there. Lifestyle, weight management, smoking, physical activity, these are fundamental on how we live well with our diabetes. We can even reverse it. Similar to cardiovascular, these are all cause mortality things that we can improve. So this slide is just a little bit more technical on what the sort of the different terms mean. So when we say 8 care processes, these are the measurements that we take, your body mass index, your blood pressure, that's your sugar level, and then also refer you for retinal eye screening. The retinal eye screening element is the 9th element. Treatment targets. This is probably the more difficult thing to manage. So 3, it measures your sugar level. That needs to be good. Blood pressure needs to be good. Cholesterol needs to be good. And to say you've achieved on your 3 treatment targets, you need to achieve on all 3. Not just 2 out of the 3 or 1 out of the 3. That doesn't count. This makes it really difficult because these dependent factors is dependent on the person. And it is not a quick fix if we need to apply lifestyle measures, if you say, I want to lose weight, you're not going to lose weight within 1 month. It is most likely 6 months. It is a lifestyle change. If you want to focus on stop smoking, and that's your more important rather than losing weight, then that is your key focus. So it is really dependent on what is important to the person. Say if we were to make medication change, even medication change needs to give some time before you can incrementally increase it. So this is sort of our restore program. So what have we done across Bob and obviously in West Berks to help restore services and everything get back to pre-COVID levels? Yet again, we were fortunate to invest in a local enhanced service so that practices can take part in this. This is so that all practices can focus on their 8 care processes to try and achieve your 3 treatment targets. But I draw your attention to this first paragraph because this is how we approach patient care. It is a focus on the patient as a whole, as a first instance. What is the patient's needs? Secondly, empowering that patient to understand their diabetes and be able to live well with their diabetes. Absolutely fundamental. The patient being a key part in how we deliver the service. Then, so part of how practices can be using that enhanced service, what was offered is upskilling of clinicians, because the clinicians need to understand too how diabetes works, what do the numbers mean, how to encourage patients, how to try and make that concept of every contact count, and thereby continuing their professional development. We are really fortunate. So in West Berks, but actually in Berkshire West, our diabetes clinical lead, Dr. Balaji, actually made practice visits. So went to each of the practices to see how they are doing. How are they getting on in their restore program? What are they doing well? And being able to share good practice with others and identify if there's some key pinch points, and just to see how the system can help support them. The slide just talks us through what's in the structured diabetes education programs, which are national programs, and there's also a national digital education. Last slide, you'll be pleased to know, this is just looking at the numbers to see how achievements are. And if we look at so this is looking at the different PCNs and looking at how they are achieving to that 8 care processes I spoke to you earlier about. And you can see that they are achieving quite well. And, you know, how we say well is how do we compare to the rest of Berkshire West. So we can actually achieving better than that, and certainly much higher in the 8 care processes than national. The 9 care processes, similar, although the numbers are low, it is all in context with how everyone else is doing. And according to national, we are still well above that. Here's the 3 treatment targets. And if we can reflect on what I said, this is harder to achieve. So we can bring patients in, make the changes, but we need to give due time to allow for those changes to make a difference. And the other thing that I pointed out in West Berks, our prevalence also increased. So we have been picking up more patients that actually went from maybe pre-diabetic to diabetic because of our enhanced service. So there's actually more diabetics now that need better control. So in the 3 treatment targets, overall, we are achieving relatively on par with Bob and with national. I'll venture to stop sharing my slides. Stop sharing. Did that work? Am I back in the room?
Mm-hmm. Okay, thank you. Would you like us to put questions now, or?
Yes, thank you. By all means.
Okay. But basically, when someone's diagnosed as having a problem, what sort of support is offered? I mean, still are there free referrals for free gym, or is there, so what sort of support is put forward?
I think the most important thing, so there's pre-diabetes and then there's diabetes. Lifestyle is huge. There's a huge management in that. So that if it is pre-diabetes, there's a national pre-diabetes prevention program that we can refer you to. And this talks to health and education and exercise and speaks to all those things. And in the second to last slide, there's the structured educational programs that are also nationally set, because the patient and the family are encouraged to come to those structured educational events, because it's not just the patient at the end of the day that is affected. The whole household ideally needs to change food choices, activity, and so forth. And importantly, is the recall system too.
Obviously, there's cooking skills and food choices and all those things.
Exactly, fresh fruit instead of I would imagine all of those things.
It's very difficult to sort of change habits in a family that have gone on for a while, and obviously cost of living and processed food. I mean, it's a really big issue, isn't it? Changing. I don't know how much we can do there.
And that's just why I stressed, Chair, about involving the patient in that, because what we also need to take into consideration is what is important to the patient at that point in time in their lives. You know, we show them, this is what your blood pressure is, this is what your weight is. If it is their priority at that point in time to address smoking, then we should allow that is the most important thing for the patient, instead of saying you need to fix 5 things and feel quite overwhelmed by what needs doing and might disengage. So we have to involve the patient in what is important for the patient. We can say, these are your numbers and this is what it should be. But all lifestyle interventions make a big difference in diabetes.
And do we have obviously different practices? Do they have different support, or are they offering different help? So do we see a big difference in diagnosis or support or prevention in different practices?
I pointed out that we were quite fortunate in Berkshire West in having the enhanced service since way before COVID. So that's an investment that practices can sign up to. It allows education for staff members as to how to approach it, what do the numbers mean, how to incentivize and encourage patients. And that is available to all practices. I also mentioned that our diabetes lead actually physically, virtually these days, did practice visits to find out from practices what are their pinching points, how are they doing, how are they catching up. And I think that also from looking at the numbers, seeing the pre-COVID numbers, how the number of diabetics increased and that we were actively seeking them because people may not present. If you don't look, by getting it when you're pre-diabetic, you're not symptomatic, you're not unwell yet. This is proper prevention. So we're stopping it in its tracks with this earlier detection and hopefully undoing it altogether.
Thank you very much. Yes, I have a question on the socio-economic aspects of your, clients, if I can put it that way. I mean, clearly, we're all aware that we're in a cost of living crisis and a lot of people are struggling a great deal. And convenience foods, cheap foods are, as we know, highly processed and often and full of sugar. Could I ask, what sort of strategies do you have for helping in that situation? And the other thing is that your data, does that break down into socioeconomic data as well? Thanks.
Thank you, Councillor. Absolutely. Diabetes and cardiovascular disease, for that matter, is disproportionately affected to deprivation, ethnic minorities, and certain ethnic minorities within that. Absolutely. We just used national data to share with you in that slide deck. We're very fortunate in Berkshire West to have different forms of business intelligence to really do some targeted work around the inequalities around diabetes. So we can go searching for them. So yes, so I think that was the second part of your question. The first part is actually a plea to yourselves. as councillors and newly elected members to see how can you help us in that. You know, how many fast food stores there are on the high street as compared to opportunities of buying fresh fruit, opportunities of cooking, teaching cooking, fresh cooking, and it's actually cheaper to buy ingredients and make 2-3 meals instead of one meal. But all too often do we get specials that sound wonderful, and if you're tired and a young mother, you know, a 2 for 3 deal or that type of specials that you get is just more convenient because you're busy and tired. So I would love assistance to see how we can really get that message across of healthier eating and just the benefits. You know, what does healthy life look like, rather than chastising, don't get sick. You know, it is not good to be overweight. Rather, if you lose half a stone, 1 stone, how much better you feel in yourself. So selling that healthier message.
I think Paul wants to comment.
Thank you, Chair. Yes, I was going to make the point that it's very positive that a colleague of mine in the Communities and Wellbeing Department has written something called Health in All Policies. Now, you have to forgive me, not quite sure how far it's gone through the process. Catherine might be able to bring me up to date, but essentially that is exactly as it sounds. How can we make sure that when everything from a policy perspective that the council does is informed by, mindful of the health impacts on our community?
Did you want to comment, Catherine?
Yes, I can just confirm that health in all policy approach has been approved through the internal corporate approval system, and my colleague Elizabeth Gowans is kind of, as we speak, working with colleagues across the council to roll out the health in all policy programmes, and that will include working with colleagues in planning and other colleagues related to, you know, as well, you know, looking at how we can develop our neighbourhoods and communities, and, you know, as it says on the tin, always in decision making and, you know, policy development, always having health in mind, as well as the other factors in developing policies and plans across the council.
So this includes things like active travel, and maybe patches of land, more allotments so people can grow their own veggies if they wish to, things like that.
Yeah, so again, we do have active travel programmes. So again, my colleagues within the public health and wellbeing team do work on active travel across the life course. There's been current and I think recent surveys across the life course about attitudes and experiences around access to active travel within the district. So again, that's definitely a programme within our public health and wellbeing team at the council.
Thank you. Just worth saying, to clarify, that doesn't mean that health will be the main consideration in all things. Obviously, it has to balance off with things like the environment, etc., etc. But it's making sure that health is considered, the health impacts of our policies are considered as part of the process.
Comment first.
Yeah, thank you. Just a question about the slide number 8, or it's slide 11, the one with the achievements on it. Could you just clarify what the term achievement measures? I was just a little unclear. So the achievement percentage on, and also on both care processes and treatment targets, because you also mentioned a time delay, I thought, between processes and targets. Could you just...
That's right. Was that the very last slide that I presented? Sorry, because I reshuffled my slides.
Sorry, it's the table where you say care processes. So like, for example, West Berkshire, just under 59% achievement of the 8 processes. What does achievement mean? Just to clarify, sorry.
Okay, so it is getting all 8 care processes. So similar, yet again, that all or nothing, sadly. So if you achieve 7 out of the 8, you're not counted as achieving 8. So sadly, it's 8 or nothing. So how many are achieving full 8 all the time?
And is that then, for example, 59% of the people that
with diabetes
think need the 8?
That's right. That's right.
Yes, okay. And then similarly, the targets is 34% of the people who. What does the target one mean then? Why? What's the? Sorry, it's probably obvious. What's the difference? What's the reason that for the people in, for example, West Berkshire, the 59% who had all 8, it's 35%. What does the 35% treatment target mean again? Sorry.
Are we still on the same slide?
Oh, actually, yeah, it's the other stuff, isn't it? It's the other list. It's I forget what it was. It's the cholesterol check and the other things. So the people who've had the 8 processes then have it's just less have the treatment. That's the bit I was a bit confused about. There's obviously a good reason for it, but I don't completely understand.
Yes, is that the difference between the 8 and the 9 care processes?
And the 3 treatment targets, I think.
And the 3.
I think
yeah,
Sarah Bay wanted to comment there, possibly.
So I think what you were asking is there's different percentages between the achievement of all the 8 care processes, and why is there a difference in the 3 treatment targets?
Okay.
Because they cover different elements. So the 9 care processes includes retinal screening.
So say you can have all of your tests done, right? But your blood pressure is not well controlled. So then you will tick the box that you've had the 8 care processes done, but because your blood pressure is not in check, we're not achieving on the 3 treatment targets. And yet again, the 3 treatment targets is an all or nothing. So if you achieve 2 out of the 3, it is considered not achieved, sadly.
Oh, got it. Thank you. That's really clear. Thank you.
Thank you very much for that. Councillor Jeffrey?
Yes, I suppose it's. I'm going to suggest something very big for our little health scrutiny, but it is fairly serious, and that is, should this not be the subject of national television advertising, trying to get these concepts across at individual practice level? I declare an interest because Thatcham is obviously my practice. But I think these are messages. It's a bit like if you go back far enough, those of us that old, keep Britain tidy. The message went away completely. It's never been pushed for the last 50 years. And everywhere you go is a sea of litter. In exactly the same way, if you are actually putting out that message that you need to be checking this, checking that, then I would have thought that would have some kind of benefit nationally right the way across the piece, and it will get people used to the concept that, my gosh, maybe I might have a diabetic situation, and there's something that there is actually something medical that can be achieved by going to see the doctor about it.
Councillor, I couldn't have said it better, and I would love for that. So actually, this week is National Diabetes Week, and exactly. And how many of us around this virtual table are actually aware of that? And for me, it is things like that on how we should our comms teams. And I declare I'm also, on the Health and Wellbeing Board, and saying that part of our plan is prevention. And part of prevention is we need to reframe things. So before it becomes a problem, so you're still feeling well, how do we identify things earlier? How do we help promote what is diabetes? Aligning local authorities comms with ICB comms, with national comms. If we back onto each other like that, surely we will reach all the messages. How do we get this message into schools so that the child goes home and tells mum and gran, it's diabetes week? The child might not get the full concept of it, but brings that message back. So completely echo and think that's a wonderful idea, and hopefully something that we could make sure is in our strategy.
Well, maybe through the council, obviously we've got contacts with schools. We could be sort of pressing messages out, and through our own staff. We're a big employer. So, you know, we could be sort of an example to other businesses. This is the information you pass on to your staff. This is how you support your staff. I mean, we've got a big sort of mental health first aid program. So, you know, all these things, we sort of taken advantage of getting the information out there in some sort of positive way. Or we arrange, I don't know, sort of more lunchtime walks or something, you know, just to sort of get people out of the office. You know, so there's all sorts of things one could do, but it's the time and the resources and the making it of prime importance. Yes.
Yeah, thank you. This is obviously a very simple question to ask, really. In the areas, we've got Kennet, West Berkshire Rural, West Reading Villages, and we also have the A34, which rather intrigues me. Could you elaborate what exactly the A34 is, please?
No, that is actually the name of our the PCN, and it is grouped with Strawberry Hill, Downland, and Eastfield.
Thank you very much. I thought you were referring to a road there.
Me too. One other question we haven't touched on is sort of cultural issues and whether this is something that's being addressed dietary wise, and you know, is this a problem? Is this something that is being addressed?
Whatever we're doing, Chair, we could do more and we should do more. And that's yet again getting, how do we reach, we try and tailor make it as an individualized the patient when they come into the primary care and speak to their healthcare professional. But how do we make that even better? So even the structured educational programs will be sensitive to cultures and so forth. But I think whatever we're doing, it could be more. You know, how do we reach out to different faith groups? You know, started at the core messages, and I'm sure all of us could make whatever treats that we're making, make it even healthier. So I agree, whatever we're doing, we can and should do more.
Thank you. Paul wanted to comment.
Thank you. And I'd entirely agree with what Ike said in terms of we can always do more. But saying reducing health inequalities is very much a topic of debate, discussion at strategic level in the relevant policies. So I think there's a shared commitment across the system to reducing health inequalities.
Thank you very much. Yes, Catherine.
I think I mentioned earlier, Chair, that I am working with colleagues to commission a targeted NHS health checks outreach service. So that is very much focusing on reaching our residents who are disproportionately impacted by cardiovascular disease and also type 2 diabetes as well, but who are underserved by our universal services. So we're building on the experience that we gained during COVID. So when we did our targeted outreach for testing, when we did it for our vaccinations, and also the more recent targeted outreach work that we've commissioned, again around just yesterday, in terms of we had an outreach clinic for our spring 23 COVID vaccinations, and also over the winter period we targeted or we ran a targeted outreach service called Be Well This Winter. And again, that was outreach that included flu vaccinations, it included COVID vaccinations, it included signposting to our cost of living hub, and included signposting to the NHS health check service as well.
So there's a lot going on. I've got a specific question here about whether you know what percentage of patients are diagnosed with diabetes are receiving eye screenings annually. Is that a figure you're aware of? Because obviously that's a big risk, isn't it, once diagnosed with diabetes?
Absolutely. And that's why that is the 9th care process, or something that will be checked on every year. Unfortunately, I don't have a figure to hand. I can only apologize. we can send that information through by email if that's okay. What percentage people have had the eye screening?
Thank you very much. Fiona's got her hand up.
Yes, hello. I was just having a quick look whilst you were giving your presentation and talking about it. And I was having a look just to see what comms are out and available around diabetes for West Berkshire. And there's very, very little actually that I can see. Obviously, Healthwatch would always support you with any comms, but I can't find any. So that seems to be a bit of a problem. So and what I have seen, it's very corporate in look, you know, and I think perhaps if there was some comms put out that were maybe a bit more consumer friendly, as it were, I think that would probably be a bit more eye-catching, a bit more for people to relate to, really, rather than something that's very formal style. But I think hitting the comms hard and fast is probably a really good way. And of course, we would absolutely love to support you with that.
Thank you so much for the offer. And where we put these comms, Fiona, is also important, you know, so not just in places where you're seeking help, you know, it should be close to shops where you're selling and in our supermarkets, and, you know, I think the placement of the advert is also where we reach our target audience.
Thank you. Councillor Jeffrey?
I don't know how many people saw it at the time. I would think that our doctor would certainly remember it. But within the Thatcham practice, there was a doctor who got a gentleman who was the first time that I'd heard of it, was it 2-3 years ago, that actually was rescued from type 2 diabetes and was free of diabetes, and it was a whole program of it, and a resident of Thatcham, and that it was a mixture of changing diet, but changing the amount of exercise and riding a bike and running around Green and Common and all these kinds of things, and he actually stopped having type 2 diabetes and no longer had type 2 diabetes. I would have thought that which was on South Today or ITV, it's on one of those local programs, and I would have thought that if the gentleman concerned was still prepared to allow it to be used, I would have thought that was very, very powerful in this area, because it was absolutely local. It was in Thatcham, and I think it certainly hit me. It certainly hit my mind, and I couldn't believe that it had happened, because I thought that diabetes, once you had it, that was it for life.
It feels wonderful to hear positive stories like that, and it's far better than any prescription someone can give you, is to know that your neighbor can do it, so surely I can do it. I think the message that it sends out is powerful.
Positive things. Yeah, definitely. Well, thank you. Any more questions from members? No? Well, thank you very, very much to our presenters for that. Any suggestions about further work, or that we think could be done here, or later feedback? Anybody got any comments about that?
Well, once again, I think, a follow-up would be really good, because we've highlighted these two areas, dementia and diabetes, as, challenges for us. We've had a very informative afternoon. So I think if we were to have a follow-up and see where we are at, an appropriate future time, that'd be really helpful, and see how we can build on the progress that's already obviously being made.
And see what initiatives might be working as regards prevention.
Exactly. And also it will give the practitioners an opportunity to come back to us at the council to see how we can work, in partnership. Yeah, exactly.
Definitely. Thank you for that. And thank you again. Thank you very much for attending. Oh,
thank you.
Just one.
Thank you.
Sorry, I've just got one follow-up question. We've lost the... Don't worry. Oh, okay. I'll ask the question. Is there anything going on in sort of early diagnosis using IT, I suppose, which is meaning, for example, trends in noticing, for example, people's blood tests that they might have for other ailments just routinely gathered, or I forget what the other treatments were, but the idea of when a patient is in the GP for something else, gathering up information, which then, not necessarily artificial intelligence, but piecing it together to then hint that somebody needs further investigation. Does that apply here?
Shall I pick that one up? So I think in terms of using data and intelligence to, Dr. Feltman talked about use of connected care, which gives us quite rich data locally and allows us to marry up various information around accessing service, results, etc. There's a number of things that I'm wondering whether you were thinking about sort of point of care testing, or are you, just to clarify, from using information in the practice? I just wondered what your thoughts were.
Yeah, I was sort of thinking of trends. I've heard it said that for other illnesses, sometimes trends that don't necessarily point to a particular diagnosis can be used or potentially helpful. And I don't know, I just wondered whether that was applicable here. It sounded like it potentially was because of the tests that are done.
Yeah, so I think we could definitely draw from some of the trends, and perhaps that's something that if we come back again, we could pick up further. That would be helpful.
Thank you.
Okay, thank you very much. Oh, yes, Catherine? Yeah.
I don't know if this is helpful in answering your question, but in terms of clinicians, when they have a patient in front of them and they're thinking about CVD, cardiovascular disease risk, diabetes risks, they can sometimes do some opportunistic tests as well. So again, some of the NHS health checks are done opportunistically, or a blood test for your blood sugar level can be done opportunistically, and there is a piece of equipment called point of care testing equipment, so you can do somebody's blood sugar there and then, and also somebody's cholesterol as well, which is really important in the outreach in terms of testing. So even if a patient maybe has not been picked up in terms of the searches, who may be at increased risk of diabetes and hasn't been, sort of identified that way, just, you might have a patient in front of you and you having a discussion with that patient, having a look at the overall picture, you might then offer them a screening test for type 2 diabetes.
Oh yeah, thank you very much. That's exactly the sort of thing that's very helpful. Thank you.
Thank you very much. Thank you very much for this. Okay, so I think that's it for diabetes. So thank you very much again. And thank you to Sarah. Got two Sarahs. Sarah Bow. Are you staying with us, Sarah? Or
I'll leave you now, but thank you for inviting us.
Thank you to Heike again, who's
I will do. Thank you.
Thank you for attending, and we'll see you again in the future. Thank you.
Thank you.
Bye-bye. Thank you. Right, we've now got item 8. Thank you, Sarah Webster, for waiting. Sorry, we're probably running a little bit late. Hope we're not sort of holding you up from something. So Sarah is going to provide us with a brief update on integrated care board activities, commissioning plans, and an update on the formation of the integrating care board. Is that right?
Yes, thank you, Chair. So I usually come along to give a general update on everything going on in the world of the ICB. So it covers all of those areas you've mentioned, but also a specific ask to update on some work around virtual wards that I'll cover as well. But just as a quick introduction, so I'm Sarah, I'm the director that covers Berkshire West within the Integrated Care Board. As a reminder, given the acronyms of multiple organisations, so the Integrated Care Board is the organisation that covers Berkshire, West, Oxfordshire and Buckinghamshire. And at our core, we are the NHS Commissioner, but in reality, our role is much wider than that in terms of the role of a convener of different organisations across the system to come together to help make improvements to improve the health and well-being of our shared populations. So that's the ICB. And if we talk about place, that means Berkshire West, one of the 3 places, so Berkshire West, Oxfordshire and Buckinghamshire. Obviously, within Berkshire West, we've got Wokingham, Reading, and West Berkshire. So it's a slightly complex, health construct in terms of how we break up the geography. But I hope that helps you place me and my role in the organisation that I work in. So we prepared a written update for the committee. I'm not going to talk through every single part of it as you've had a chance to read it in advance. I will just pull out a couple of key bits though that I think are of more interest. So first of all, just to follow on quite nicely from that previous conversation, we are working up proposals across the Berkshire West patch to deploy some inequalities funding that we've got through the ICB, which is a total of 2.6 million over a 2-year period, so the next 2 years from now. And we're forming a community wellness outreach model, so very much in line with, as Catherine's just described, how do we take our services out to those communities that we're currently not serving to the same level, because for various reasons they aren't accessing the services that will help to improve their health and well-being. So we are working on that with partners across Berkshire West, and then we'll really localise that, so what is right for the residents of West Berkshire. But beyond that, we're talking sort of potentially street level. How do we really target those communities and take things out to them in a way that is the most accessible way of delivering some of our services? Initially focusing on enhanced health checks, noting that the impact that may have on reducing the level of cardiovascular disease and therefore the knock-on impacts of that on the individual and their families. But actually the conversations we've been having here has prompted some wider thoughts on this, because often there's two parts to this. There's identifying those people who are potentially at risk of developing something. So how do we get in early and help them not become more unwell or develop something like diabetes? But often the answer is the same. It's more exercise, it's eating healthier, it's having access to the right facilities. So there's some broader thoughts there around how we might work on that as a programme in its own right. And so that's very much prompted some thoughts for me there. Thank you. The other thing I wanted to, another area in terms of urgent and emergency care. So I've got an update in the pack around how we are performing at the moment in urgent and emergency care across Berkshire West. I would just note at the moment, so this week in particular is incredibly busy. The heat and combined with the increase in pollen prevalence has really exacerbated a number of respiratory illnesses, and people are presenting at the emergency department and their GP practices and urgent care centre as well. So we are very, very busy this week. I think the Royal Berks had their busiest day ever in A&E yesterday. So whilst we often talk about winter pressures, it's very much pressures throughout the year, which are being managed, and services continue to run safely, and the teams are doing a fantastic job to be able to meet this demand. But I would just note that it is still busy from an operational perspective. Something else the paper touches on is around primary care. So the National Access Recovery Plan for general practice has been published, and we're working with our general practitioners locally throughout the PCNs to make sure we're clear on what that means for them. So this is around how do we make sure that when we phone the GP in the morning, we then get either an appointment or we know our next steps through that one phone call. We're not asked to phone back, or worse, we're not hit with an engaged tone on the phone, which is a deep source of frustration and is not something that we want to be able to move away from consistently. So a lot of work is going into, from an individual primary care practice level, what steps need to be taken to implement advanced telephony where that's not already in place, make sure that we can offer same day or within 48-hour appointments where it's urgent, and certainly within 2 weeks, in line with the national guidance for more routine primary care appointments. And also continuing to focus on the additional roles that we've spoken about earlier on in this meeting, where there's funding available for GP practices to employ additional professionals who are very suitable to see residents who have a number of different concerns or ailments. It doesn't always need to be a GP themselves. And in Berkshire West, we've been very successful in being able to recruit into those sorts of roles, and have been able to spend almost all of the funding that we've been given to be able to support those sorts of new staffing models within GP practices. So along with that, we know we need to do a bit more work around communicating that with residents, because sometimes it's actually then a source of frustration that they wanted to see a GP, because that's always been the traditional model of primary care. Whereas we need to reassure and remind residents that often it's better to see a nurse or a paramedic or a therapist or whoever it is that you're signposted to when you make that contact with primary care. So we're working on that as well. I will then also just talk and highlight around the virtual wards, which is something that I understand was of particular interest to this committee previously. So a virtual ward is largely what it says on the tin. It's initiatives that have been stepped up by Royal Berkshire and Berkshire Healthcare, so our acute and community providers, largely prompted and accelerated through COVID, but has proven to be incredibly successful. And this is where we are able to support someone to stay at home with virtual monitoring and staff that will visit them in their home, rather than being admitted to a community bed or an acute hospital bed. And this is proving to be very successful, and we've included a couple of case studies in with the paper to really bring to life what that means for the residents. Their stay, effectively, where they're being monitored as part of this virtual ward, is generally shorter. They're able to stay in their own home. Just looking at the stats, 75% of people who go along this pathway avoid coming into hospital completely. And the remaining 25 are people who are able to return home sooner than they otherwise would have done, because they've been in hospital and reached a point at which it's very safe for them to return home with a level of monitoring that prior to having this service in place, they'd have had to remain in hospital for that final part of their pathway. So really, really successful, and something that I think really embodies the ambition to bring care closer to home and keep people at home for as long as possible, because we all know that's the place where most people would rather be. So one of the case studies in particular is a particularly good example where historically the individual, it's the first case study for the Berkshire Healthcare example, where that individual was able to be managed at home, which sadly it transpired that was in the last few months of their life. Whereas had they been admitted into hospital, that completely changes that period of time for that individual, for their family and their loved ones. So being able to support someone to stay at home rather than having that big disruption of coming into a hospital setting, just really brings home the personal impact that this new service is having. So we're looking to develop this further. So at the moment we have 108 beds. Obviously they're beds in people's own home, but we treat them in terms of staffing and technology needed as beds. We're aiming to increase that to at least 120 in this financial year, and then look beyond that. And we're also working more closely with social care at the moment, so colleagues within your organisation, to improve the links between those virtual wards and then social care services, both in terms of being able to potentially refer in, but then also how we transition from a virtual ward bed to someone then having longer term social care where that's needed as well, and how we can make that seamless, really. So lots of further work underway, but it's a really, really positive direction of travel. I think they were the key things I wanted to highlight from the report, but very happy to take any questions and also to clarify anything if there are any acronyms or funnies in there that aren't completely clear, noting the opening remarks. And I think in health we can be quite guilty of that sometimes. So please do let me know if there's anything in there that's not clear.
Thank you very much, Sarah. Can I just ask the numbers of A&E the attendance numbers? Are they appropriate? Because quite often we still get people going to A&E when really they should be accessing their GP in something local. Is that still an issue? Are these appropriate attendances?
So we're working really hard to make sure that people are able to access the right service for them. I don't tend to use the word inappropriate. If someone feels they need to go to the emergency department, we need to acknowledge the fact that they have a need that needs to be met, and whether it's the right setting or not is one that we're looking in. So there's work underway at the moment to look at how do we best manage that same day urgent need. working with primary care and with the acute hospital, and considering our urgent care service in Reading Centre as well, to make sure that they are best set up for meeting that need. But yesterday in particular, as I said, we had over 670 attendances at the Royal Berkshire, which was 230 more than we were typically expecting, so significantly higher. And so these are pressures that we need to work through in terms of a long-term response.
Because people tend to go to A&E because they can't get to see their GP, or they just head off there and prepared to wait because they find it easier just to use it like a drop-in service. That's what I mean by appropriate.
Mm-hmm.
It's not what it's there for, is it really?
No, so we do still get some feedback around that, although we do appreciate that primary care are exceptionally busy as well. So we know there's not one single solution or answer to the situation, but there are still people who are going to A&E that could very well be managed in a non-acute emergency setting.
And also the inequalities funding, that sounds exciting, but
yes.
Finding out how best to use that. I mean, you said a little bit about it. Are there any specific initiatives that you've got in mind, sort of concrete examples of what you think you're going to do there, local things?
So we've been discussing sort of and getting the balance right between something that is, from my perspective, consistent across Berkshire West, but also allows for local tailoring to meet the specific needs of residents in West Berkshire or Reading or Wokingham. So where the discussions have gone thus far is that creating that kind of community outreach vehicle. So what's that? So how do we consistently get primary care involved? How do we have the right sort of project management and support to oversee that? But the actual then how it's delivered and what's delivered specifically may vary depending on specific need. So, for example, we think a core offering should be that we want to be able to reach communities and be able to do blood pressure checks and a broader NHS health check as a core offering, that whoever we're reaching in any of our communities, we should be offering that. But then we know that there are other services that we might want to add on to that, depending on a local need here in West Berkshire versus other areas, and even within an individual community. So we may know that in some given communities, having a conversation about social isolation and signposting to befriending services or more social prescribing is more important. And so we'd want to focus on that in maybe one locality, whereas in another, it's more important to be having conversations around sort of perinatal maternity support because of the data showing us that that's more beneficial there. So we're getting quite clear on what the core offering should be. And then the next step is discussing within the local authority area what those supplementary offers need to be. So we're really tailoring it to local need.
So you'd be looking for possible suggestions, people who identify about projects that might be appropriate for the use of this funding, sort of, ways of accessing people that are a little bit different, or places to go to or something like that. Yeah. Yes.
So we've been working very closely with public health and colleagues from within West Berkshire as part of the starting point of the project. And the next steps are that we'll be having conversations through the West Berkshire Integration Board, which has key partners and stakeholders to be able to influence the next stages.
Catherine is nodding about. Did you want to comment?
Yes, just to clarify and confirm. So we are very much within the Public Health and Wellbeing team, working with our service director, April Pebbody, to have the service specification up and ready and align with our colleagues in the Berkshire West Bob group that are looking at this health inequalities funding. So we are very confident that when all of everything has been agreed in terms of finance, in terms of what the specification is going to be and what is going to be required, that we will be ready to commission and mobilise the service.
Thank you for that. Councillor Jeffrey?
Yeah, a couple of questions. On page 41 of the report, one of the bullet points is building the role of community pharmacies, including consultation on prescribing antibiotics for a range of common conditions. I thought that we were, as a worldwide society, trying our darndest to wean ourselves off antibiotics as much as we possibly can. Is this actually a sensible move forward if we get the local pharmacist prescribing an antibiotic and dispensing not just dispensing, but prescribing an antibiotic for somebody? Don't we need to be doing more controlling of antibiotics rather than less?
So I think that is absolutely a risk around general antibiotic usage, and we need to make sure that as a health service that we're only prescribing antibiotics in appropriate circumstances, and that residents understand that as well and don't come with an expectation that everything should be given antibiotics. In terms of who's doing that, there's the national policy and national announcement a couple of weeks ago around funding to support increased capacity within community pharmacy to enable them to do that. And that acknowledged that actually that there is an appropriate level of clinical professionals that can prescribe with a level of training, and we're working through the implications of that announcement at the moment, which will alleviate some pressure from primary care for some of the sorts of ailments that have been outlined, but obviously within clear clinical guidelines, and not just inappropriately prescribing. Of course, that wouldn't be acceptable.
Thank you. Councillor Cott.
Hi, yeah. Firstly, very interesting about the virtual ward. Maybe not for now, but I wonder whether it also covers smart home kind of monitoring. Does it, for example, do? I suppose the question perhaps is: are you talking to other health authorities and maybe even other countries? And I may be slightly on the wrong wavelength on it, but I've certainly seen case studies where, for example, you monitor whether people have got out of bed or not, whether they've boiled the kettle today, those kind of things to work out, which is more to do with living in the home for longer. I'm guessing this is what you're talking about is more to do with dispensing medication, or is it both?
So this is more around sort of remote monitoring of the individual. So we know that they're unwell, and we know that they're able to be set up with their level of remote direct monitoring. But you're absolutely right around that more kind of the ability to keep somebody well at home by monitoring the examples as you've given. Another one is, have they opened the fridge today? Sensors that can let you know those sorts of things as well. So when we're looking at our pathways that are avoiding people having to go into a residential care setting, those are the sorts of things that we need to be considering. And I know Paul and I, Paul Coe, have had some initial conversations around this and whether it's something that what programme of work might be needed if it's not already in progress. So yes, it's very much something that I think we ought to be exploring.
Okay, thank you. Councillor.
Thank you.
Thank you, Chair. Yeah, I was just going to say exactly. So telehealth and telecare are complementary functions, but certainly we're part of an equipment service where we've got good access to the latest telecare, and we prescribe it actively. And that one of the things that does for us is help to keep people safe. Yeah.
Yeah, thank you. And great. Yeah, because another example, just anecdotally, my dad was diagnosed with a pacemaker. Sorry, he needed a pacemaker, but that's because we realised he was browning out when we were in front of him. But people like that would benefit from and technology has come on quite a bit to detect whether people have fallen over like 3 times in the street this month, sort of thing. So the other question was on the primary care. I couldn't help notice you seemed to say there was a target of 2 weeks for an appointment, if I heard that correctly. And also you mentioned, I know it's come up a couple of times today, about the change in the model. I guess I should say in our area, which is Burfield and Mortimer, which is a village, the perception is there's no sign of that other model, meaning it's either the GP or nothing at the minute, and probably appointment times for about a month. So the concern is that although people can get the emergency appointment when they need it, I don't think there's any question there. There's a lot of people who say 3 to 4 weeks is typical, and they'll probably not go. I know there's an element of, I mean, one of our doctors used to be legendary for saying, when you saw him, how long have you had the problem? Then we would say, we've had it a month, that's why I'm seeing you. And obviously there's an element of that, but we're getting probably 3, sometimes 4 week wait times for a so-called routine. And you can't get a nurse, you have to go for a blood test, you have to go to Thatcham or Royal Berks, where we are. Sorry, that's a bit of a loaded local question, but It's just because of the 2-week comment.
No, it's helpful, and we know that there is variation at the moment in individual practices' ability to offer routine appointments within 2 weeks. That's the ambition, and we're working with each practice individually to understand what it is that is needed to be able to offer that service consistently for our residents. And similarly around the additional roles. So I've made a note and I'll follow that one up as well in terms of the specific practice.
Thank you very much.
Councillor Ford.
Yes, thank you. I've got a question following on from Owen's comment earlier about community pharmacies. I mean, clearly we've got a major problem locally because of the closure of pharmacies in local supermarkets and things. And if the pharmacists are to be expected to take some of the load off primary healthcare, GPs, have they got the capacity to deliver that service? And are you getting any, or is there any prospect of increased funding from central government to cover that? Because clearly the system couldn't manage at the moment, I would suggest.
So there was an announcement of additional funding along with this announcement in policy. We're working through what that means in terms of how that flows through into different systems and locally. So it's still fairly early days there. And similarly, in terms of how we then make that a reality in terms of actual provision by individual community pharmacies. So this is a work in progress and something we can bring back a further update on to a future committee to keep you all appraised of that. In terms of the specific local provision and some of those concerns, that's been something that the Health and Wellbeing Board has been reviewing and discussing, and it's within the remit of the Health and Wellbeing Board to consider where there's a pharmacy closure, does that have a significant negative impact on the pharmaceutical needs of our residents, and that process has been considered through the Health and Wellbeing Board and will continue to be reviewed.
Okay, thank you for that. Yes, I was wondering on the same issue, how can they be asked to do more when their numbers are decreasing, because they're becoming increasingly important, aren't they, pharmacies, for sort of basic health checks and things. Thank you for that. Any more issues anybody wants to raise? No? Okay. Well, thank you, Sarah, for your report. I'm sure, obviously, we'll be having constant updates about probably most of those issues. I don't know if there's anything specific people want to raise, but, I think it's all basically things that we will be hearing again. I'm sure the pharmacies and GP surgeries, how they're coping with appointments, those sorts of things. I think they're obviously constant things that we'll need updating on. So thank you very much. Thank you for your time.
You're welcome. Thank you.
Bye-bye. Thank you. Fiona, thank you for waiting. Last but not least, well, almost last. Right, this is Fiona Warby of Health Watch, who is going to update us on Health Watch's current activities and feedback from local residents.
Hello there. Hi. Yes, nice to see you all. Right, so what we've done recently over the last few months is we popped a survey out into the community to find out what people's thoughts about their health issues were. And we had quite a good response from the community. And on the back of that, we have actually now worked out what our priorities are going to be for the coming year. And also things that we are going to be monitoring as well. So in Health Watch West Berkshire, what we do is we set a list of priorities of things that we actually want to look at, investigate more and work on. And then the watch list is what we are monitoring. So there may be things, I mean, at the moment, phlebotomy is on there, for example. And then what might happen is phlebotomy might come up much further because of the long wait times, etc. And then we will then start to take that on as a project and look into it a bit more. So that's really where we are at the moment. So I will tell you what our priorities are. So just bear with me 1 second. I did send that over to you. Right. So what we're doing also in West Berkshire, we're having a complete refresh of Healthwatch West Berks. I'm sure you are aware that we've had a complete change in team and service. So what we're doing is we're getting out in the community a lot more than we used to, and we're just refreshing. So we noticed that when we were going to the doctor's, surgeries, dentists, etc., we weren't in there. There was no information about Healthwatch to be seen. So we are remedying that now. We're getting the team out and about in public, getting our comms out there. And on the back of that, we started to hear a little bit more from the community, which is really good news. So so now we've started our refresh. We've now got our proposed work plan. So from the feedback that's coming in to us, and also from the feedback that was responsive to the survey, our priorities are GP services, which is the first one, which is access to. We had a lot of feedback saying that they were, with the new ways of working that is coming into the GP surgeries, the community seemed a little bit confused about who's who. That perhaps, when the receptionist is trying to help you and triage you, they don't understand that, and it's causing a bit of angst against certain populations in the community, mainly the elder generation, who are not quite sure of the changes because perhaps they don't have the digital engagement that a lot of people do. So this information hasn't been reaching them perhaps. So we're going to be kind of looking at that. The second one is GP services quality of. Again, waiting list, referral list, etc., etc. We're just having a look at it really, just to see. And I think this is obviously tied into the access to. So those are the two top priorities. Also, adult mental health services, that was brought up in our survey. That is a concern in West Berkshire. So we're going to have a little look at that too. And obviously cost of living, which is nationwide, of course it is. But it's having an impact on our health now. People are not buying their medicines, for example. They're not, even though, they would prioritize food over their medicines. So they're not, keeping up with their pharmacy, prescriptions, etc. And it's having a real impact on people, and that also goes into their mental health. That's going in how they are providing for themselves, their self-care, their mental well-being. So there's lots and lots of strands off of that cost of living concern within health that we will be having a look at. And also pharmacy and prescription services were brought up as an issue, but of course that is obviously a lot to do with the closing of pharmacies, etc. We've been trying to keep them updated with any extended hours that is coming out into the community, but obviously it's had an impact, so we're just going to be kind of having a look at that really. As I mentioned earlier, we do have a watch list that we are constantly monitoring. And we, on that one, is phlebotomy, accident and emergency service waiting times. That came up, I think, because of obviously the issues with the junior doctor strikes. SCAS had a bit of an issue, which obviously they remedied up to a point. And I think that was sort of something that people were worried about. So they brought that up as well. And the Building Berkshire Together developments for the new hospital, or possible new hospital, we have been involved in those discussions and up to point, and we're still monitoring what's going on. There has been some information put out about that it might be put back because there's a big delay on funding and things, so I'm not quite sure. I think it's just watching this space at the moment. And we are following a priority of Healthwatch England, which is to monitor women's health. There's a big issue around maternity mental health. There's also about within, again, maternity, people not getting their 6-week checks after they've had a baby. And there's lots of other things. Again, women are not putting themselves as a priority and looking after themselves. And this is also something that could be with the cost of living. You know, they're sorting other things out, and that, you know, their needs coming sort of at the bottom of the scale, as it were. So, and those are the sort of things that we're going to be looking at the moment. So, welcome any questions.
Okay, thank you. It's good to hear about the priority of women's health. I know Healthwatch did do some work on maternity services during COVID or just post-COVID. So, you know, that might be something obviously that we can consider looking at as a scrutiny issue possibly as well. I don't know, maybe. Members, any questions? Oh, Paul, yes.
Thank you, Chair. I wonder if you could expand a bit on the adult mental health piece. I'm mindful that the local authority delivers some support to people with mental health needs. So does the volunteer sector. And then, of course, there are different strands within the health system. So did you have a particular focus for that particular piece of work?
Well, we were actually going to look at a piece of work. And then, obviously, the volunteer sector has been involved with the mental health. Sorry, my mind's just gone completely blank. So they're doing some things, one at Hungerford next week, which we're going to. So we're part of that at the moment. So I think that will kind of be something that we're just going to be working alongside the volunteer sector with that, and obviously within the local authority as well. So it's not going to be a specific piece of work that we're looking at by ourselves. It's a sort of generic piece.
One of the things that certainly I've seen sort of picked up from local residents is late diagnosis of autism and services for adults with autism. Would that be covered? That would be a sort of different channel here. It's sort of different type of.
It is different. Yes, there is. There has been that. With the later diagnosis, is quite a lot of adults actually are having a diagnosis of autism now. However, we haven't really had a lot of that come up within Healthwatch. But I know that what we wanted to do in Healthwatch, really, I know Voice of Disability was a part of Healthwatch a few years ago, and unfortunately, it's sort of got lost along the way a little bit. And what we're hoping to do over the next year or so is bring the Voice of Disability back up again in Healthwatch. But again, we are a very small team, and it's again down to resource and capacity. You know, there's 3 of us, and we all work part-time. So we have a lot of work, and we can only unfortunately do so much.
I'm aware of what a small
yes
it is, but you do a lot for such a small group. It's good to see the mention of Young Healthwatch there. And I know the water side. I think I told you I'd approached them. They're definitely interested, and they have their leadership program among the young people. So they will definitely want to link in with that and do what support it.
Yes, well, we feel it's really important, and across Berkshire West, we are linking up with Healthwatch, Reading and Woking quite a lot, and we are looking at doing joint pieces of work together. It's really important to collaborate across the region to ensure the best outcome for everybody. Really, there's no point siloing a piece of work if it's going to impact us all in Berkshire West. So we're working together quite closely.
And Councillor Carter?
Yeah, sorry, you have covered it, and I'm sorry to sort of point it out. I mean, I know of Healthwatch through Alice, who I interviewed on Kennet Radio some time ago. So it's work that you do. But I noticed you only had 127 responses to the survey, which does seem statistically quite low for a survey. I mean, I dare say the outcome representative, and I don't know what the answer is, but it's good that you're obviously mindful of trying to get yourselves out there more, because I don't probably think I saw it, or at least not enough people have obviously seen that survey, which is a shame. But I'm not, the output isn't valid. I'm sure it probably is. Yeah.
Well, we wanted to try and get at least some responses from the community. We felt it was really important, and we try to get it out as much as possible, but obviously, you know, timelines, etc., it's quite difficult. However, it was quite clear, you know, when the survey came back that the GP access to was a very high priority in Berkshire West, and it, you know, well, West Berkshire, but it also is across Berkshire West. And what we'd like to do is do this survey annually, because I think it's quite important, but obviously do it much earlier during the year, so that we get a bigger response, and we can give it a really good amount of time to get out into the community and get spread around, and you know, so then give us time to analyse the results as well before we do our work plan again. However, because of the change in team that we had this year, everything has had a very, very short timeline for us. So we've had to kind of react rather than be proactive, unfortunately. However, that will be changing as we go forward.
Thank you very much. Thank you.
Councillor Ford.
Yes, thank you. Hello, Sarah. Just to say on your, I beg your pardon. I do apologise, Fiona. On your proposed work plan, Martha covered actually Young Health Watch, which, you know, what interested me was, you know, we're living through a crisis in young people's mental health, and obviously that's a massive area to try and pick up on. So Martha's already covered that, but the next point below that is asylum seekers, and I just wondered if you could share with us a little bit about what you found and what plans you might have afoot for their health needs. Thanks.
Well, as I hope you're aware, the asylum seekers report went out last year, and has been acted on. It's now been taken up in Reading and Wokingham, and they are taking that on further. I believe that we recently put out responses, requests for updates, a 3-monthly update to people that we gave our recommendations to, and unfortunately the deadline for that was last Friday, and we didn't receive any. So it's a little bit concerning that we didn't. However, within West Berkshire, I know that the Clear Springs has been spoken to. As I say, Wokingham and Reading have picked it up and are running with it now, and they have got some other providers, I think Care for Calais, and there was another one. I'm sorry, I didn't really have very much at all to do this report. I wasn't in post or employed in this area at this time. So, but there is things happening. So it hasn't just been left, I can assure you.
Yeah, I mean, members of this group might not be aware there was a report that went to the Health and Wellbeing Board about the work that Health Watch did on going into the hotels and reviewing, and that went to the council, and that's been sort of commented on. I mean, it might be something that we could forward, that Gordon could forward to members, so we can see the work that Health Watch has done if we're interested. And you were saying, Fiona, that you were wanting further comments on that. You said you
the timeline for that has passed now, Martha. Yes, we
comment sort of feedback.
So the report had recommendations, and we then give the report 3 months when we go back to have comments made on what changes have been made, as it were. Yes, but from the services that we made the recommendations to. So we're just doing our annual report at the moment, which will be coming out at the end of June, and all of this information will be in our annual report.
So we might hear more from you the next time we have a meeting about whether.
Yes, possibly. Yes,
yeah, possibly. Okay. Any more questions, members? No. Well, thank you very much, Fiona.
Thank you.
Lots going on, and good luck.
Thank you. See
you again. Thank you very much. Thank you.
Bye.
Bye. Bye. Right. So item 10, I think I've just got to provide an update on healthcare provisions in new development task and finish group. The task group met on the 17th of April, 2023, with Elizabeth Gowans, Programme Officer, Wider Determinants of Health, Public Health and Wellbeing. The Healthy Planning Protocol on Health Impact Assessments were discussed with consideration as to how the task group could influence the work. The following areas were identified: members to review the draft Healthy Planning Protocol, to be involved in how Berkshire Observatory ward data is used by developers, and to communicate with communities, and understanding the funding system and review engagement between planning and the Integrated Care Board. And this is an ongoing group. The members, Owen is the only member here, so I don't know whether he wants to comment, but it is ongoing, and the former members, Councillors Culver and Jeff Mays and Councillor Langford, will be continuing with that work, even though Councillor Langford is on this group. Councillor Culver and Councillor Jeffrey aren't at the moment, but they are still current councillors, so that will be continued with. Okay, do you want to say anything? Oh, no, nothing. Okay, okay. So that's just to note that the work is ongoing. And then just to the work programme, we can see the work programme is the last item here. I think we're looking at it. We see dementia, diabetes, we've got that. So have we got any comments there? And also this is where the stammer report, that's about stammering, is it? What's the stammer report?
It was an item that came to December's health scrutiny and just some follow-up.
It's about stammer?
Yes, yes.
It might be a sort of somebody's name or something I've never heard of.
So stammering, yes.
Okay, so also at this point, if members had any suggestions for further work, further things to scrutinise, they could bring them forward, or just to note that please think about things that you think are of concern that we should be scrutinising in future. I mean, I sort of mentioned maternity, particularly maternity mental health, COVID, post-COVID. I think that has been highlighted as an issue by Health Watch. Some work there has been done. So whether we need more follow-up there, because it's very important, and particularly from the point of view, not just for the women's health themselves, but the future, development of children. It's very much, if you haven't got a well mother, you're not going to have a well child. So it's a very important thing for all sorts of reasons. Women's health is extremely important. So hopefully we can liaise with Fiona about what work we can do to scrutinise that, or make sure we don't overlap, but we work together on those issues if we do scrutinise them. And just on the back of the dementia, what we were hearing earlier, I have a hearing issue, and I'm aware from, that hearing services are not easy to access. And I know that not getting your hearing addressed is supposed to influence it can lead to dementia, because you just zone out. You begin to think, oh, well, what's the point of listening to that conversation? I can't hear it. So actually addressing your hearing and not being ashamed of it, is really important. And there is free access checks, etc., through the NHS. But you don't get particularly good hearing aids always. And actually, I think, it's just, I think it would be useful to know whether people are accessing NHS health hearing checks, whether doctors, people are being referred. If you wanted to go privately, it's immensely expensive to get private hearing aids, but quite a few people do opt for that if they have a hearing problem. So I just think whether it might be worth exploring, people's access to hearing checks and whether they make use of them, and the links possibly to dementia and other, maybe social isolation if you're not hearing properly. That's just a thought. Okay, but anyway, we can feed into to Vicky any thoughts we have about future things. Okay, so thank you very much, everybody. I hope this seems to have been a long meeting, probably longer than it should have been. Maybe that's my fault. So thank you very much anyway for your attendance, for all the questions, and really interesting reports. So thank you very much. And we need to remain in the meeting until Gordon has confirmed that it's no longer being streamed. So if there's anybody out there listening to us, thank you for listening, as they say on the radio. Okay.